Thank you so much, Lina, for the nice introduction and for giving the rules of behavior for the webinar. I am Tommaso Simoncini. I work in Pisa in Italy, and I'm a past president of the European Menopause and Andropause Society. And it's a pleasure for me to be here today chairing this session. This is a very interesting topic, the role of progestogens in menopause hormone therapy. There are so many things that are relevant from a metabolic standpoint, from the risk of breast cancer, in terms of cardiovascular disorders and bone metabolism as well. So progestins are not something that can be chosen lightly. There's things that clinicians need to know. And so today we will have an outstanding speaker, Professor Luciano Pompei from Brazil. Professor Pompei is Associate Professor of Gynecology at the Faculdade de Medicina do ABC. Is former president of the Brazilian Menopause Society and president of the National Committee on Menopause of the Brazilian Obstetrics and Gynecology Federation. So he's really in a key position to help us understanding a little bit better the tips and tricks and why progestogens are so important in menopause hormone therapy. So with that, I would like to give the podium to Professor Pompei. Luciano, you are welcome to share slides and start with your presentation. At the end, we will have a discussion. So as Lina said, whomever has questions also during the presentation of Professor Pompei, please post them in the question and answer section of the Zoom conference so that we can collect questions and then propose them to Professor Pompei. Professor Pompei, up to you.
Thank you, Professor Simoncini. It's a great pleasure to be here, to be received by you and by EMAS. And of course, I appreciate the invitation to participate in this session. And I'm going to share my screen right now. Just a moment, please. Just a second. All right. And the theme of my presentation, the title is the role of progestogens in menopause hormone therapy. And of course, the role of progestogens is to protect the endometrium, of course. But I believe the real question, the important question is in which the progestogens are different from each from the other. That's the question, the aspects, the difference between them. In the next slide, I present my my conflict of interests. And although in the recent years I gave some lectures by invitation of some pharmaceutical companies, there were no interferences of any of those companies in the content of this presentation. And I would like to cover during this presentation, first, the medical society's positioning after WHI data publication, the difference among progestogens, and third, progestogens' new long follow-up data on breast safety, and briefly, progestogens and cardiovascular safety. So let's start, and in this slide, we can see a brief history of the prescription of hormone therapy for menopause, especially in the United States. And we can see here that the hormone therapy started to grow from the late 1930s. And at that time, the products were mainly derived from pregnant mare's urine, as you know. And the prescription augmented until the end of the 60s. But at that time, it was realized that hormone therapy was associated with an increased risk of endometrial hyperplasia and endometrial cancer. And then there was a decrease in prescription of this hormone therapy, as you can see here in this part of the graph. But sometime after, it was noticed that with the addition of progestins to this hormone therapy regimen, we could protect the endometrial against endometrial hyperplasia and endometrial cancer. And from that point on, there was again a growth in the prescription of hormone therapy. And at that time, there was the belief that this therapy will reduce mortality and cardiovascular risk. This belief lasted until the beginning of 2000, especially or more precisely in 2002, when there was the first publication of Women's Health Initiative trial. And this study at that point evidenced that hormone therapy could increase the risk of breast cancer and cardiovascular disease. And from that point on, the risk for breast cancer, the prescription, presented a rapid drop in the prescriptions. We know that there were some problems, some misinterpretations of WHI data. And nowadays we have much more deep knowledge about the limitations of that study. But at that time, the impression brought by WHI was that hormone therapy would be dangerous for women, and there was a large reduction in its prescription abruptly, as we can see in this part of the graph. On this next slide, we see that after many debates, several medical societies focused on the study of menopause and hormone therapy, published their official positions regarding the subject and considering the results of WHI. Several here known worldwide, as you can see, and I take this opportunity to introduce our Brazilian Menopause Society. Here, SOBRAC, in its last guideline published in 2018. But in this table, I highlight three of these societies: the International Menopause Society, North American Menopause Society, and the British one. And for all them, for all of them, hormonal therapy has a clear indication to treat vasomotor symptoms, to relieve genitourinary symptoms, and to prevent bone loss. All of them also bring considerations on the moment to start the hormone therapy, on the window of opportunity for starting hormone therapy, which corresponds to an age under 60 years, or a period of less than 10 years of the onset or since the onset of menopause. Another point that these societies agree, and I would like to highlight, is the aspect of individualization of the treatment. These are very special, very important point of all these international guidelines. So menopause hormone therapy is is recognized as the most effective treatment for menopausal symptoms, especially for vasomotor symptoms treatment, for decreasing incidence of all fractures, but not only for these. Hormone therapy may also relieve other associated symptoms such as joint pains, mood swings, sleep disturbance, also to improve sexual dysfunction in some cases. But the main actor here is the estrogen. Progestogen is added practically with a single purpose: to protect endometrium, to avoid the increased risk of endometrial cancer. So for non-sterectomized women using estrogen should use progestogen to minimize the endometrial risk. And the point is that the progestins are not all the same. And on this slide, we have an attempt to simplify the classification of progestogens. basically in two big groups. The group of those structurally related to progesterone at that point of the image, and the other group, those structurally related to testosterone here. And let's talk first of the group related to testosterone. We have several well-known names here, such as norethistérone, dienogist, tibolone, levonorgestrel, also drospirenone, which is also related to spironolactone. And several of these testosterone-related progestogens have been widely used since the beginning of the history of menopause hormone therapy, because they were already well-known progestogens for contraception. And at the beginning of using progestogens, there was a trend to prefer to use the well-known progestogens at that time. And those progestogens were in exactly this group. But the problem is that by having a structure similar to that of testosterone, they can also have androgenic effects. On the other large group here, those related to progesterone, that is, progestogens with more affinity for progesterone receptor without affinity for the testosterone or androgenic receptors, or at least less affinity to those androgenic receptors. But here, there are several substances in this group, such as medroxyprogesterone, cyproterone acetate, nomegestrol, promegestone, and they have different properties despite belonging to the same group. And I highlight here in this part of the figure, the image, the only retroprogesterone we know, which is dihydrogesterone. And dihydrogesterone is interesting because it has the greatest molecular similarity to endogenous progesterone. So progestins or progestogens are not all the same. They have distinct biological activities. And these activities depend on its chemical structure. On the left of this image, we can see this picture, which represents a cell, and we can see estradiol binding to its intracellular receptor, so acting via genomic pathway, but also binding to its membrane receptor. The same occurring with progesterone, binding to progesterone, intracellular progesterone receptor, and membrane receptor. But what we have to see here is that all the progestogens, of course, bind to progesterone receptor to have its action, its progestogenic action, but some progestogens may bind to other receptors, for example, androgenic, glucocorticoid, and we see here binding to androgenic receptor, levonorgestrel, norethistérone, medroxyprogesterone a little, binding to glucocorticoid receptor, I highlight medroxyprogesterone acetate, and so on. And here, this table summarizes the progestogen affinities and their effects. Here, we have some examples of progestogens, a small list of progestogens. And in the first column, we have progestogenic action. And of course, they all have action on the progestogenic receptor, of course. Otherwise, it wouldn't be classified as progestins. But you may see that some may have incredibly even estrogenic action like noreltesterone, shown here. Others may have androgenic receptor, androgenic action, like noreltesterone, levonorgestrel, in a small degree, medroxyprogesterone. Others may have glucocorticoid receptor, and I highlight here medroxyprogesterone. So the progestogens have different properties depending on their structure. And the question here is how to bring this information from laboratory to the clinic, to our clinical practice. Is this relevant, for example, for breast cancer or for cardiovascular risk? And for this, we have to remind some publications which evaluated the association between hormone therapy and breast safety. And this slide summarizes the main large observational cohort studies which study this question, this issue. And we can see here studies since 1995, Nurse Health Study, very famous study about the women's health. And they all showed an increased risk of breast cancer associated with estrogen or estrogen plus progestogen. All of them showed this. But all these from 1995 to 2011, none of them focused on specific progestins. Instead of that, they usually evaluated the effect of progestogens as a whole. More recently, there have been a greater interest in the analysis of effects of different progestins on the breast cancer risk. For example, in 2016, with the Norwegian breast cancer study showed here. And in 2019, a meta-analysis which tried to evaluate some different progestogens. And this meta-analysis published in Lancet in 2019, or perhaps it would be better to name it as a reanalysis, since data from many previous observational studies have been pooled to assess the impact of hormone therapy on breast cancer risk. And we can see at the top here that all estrogen-only preparations, estrogen without progestogen, increase the risk, similar to the previous cohort studies, by a relative risk of 1.33. Again, there was an attempt to analyze the route of administration of this estrogen. And by looking at this part of the graph, we can see that the route of administration had no influence in the risk, all of them around the same number. And finally, in down here, we can see that hormone therapy composed by estrogen plus progestogen increase even more the risk to a relative risk of 2.08. By analyzing the different progestogens, subgroups, we may see that here, levonorgestrel, noreltesterone, medroxyprogesterone, and there was no difference between them. No difference among them. All of them increasing the risk almost at the same proportion. But it's important to emphasize that micronized progesterone and dydrogesterone were considered rarely used hormones. In the case of micronized progesterone, only 50 cases came from them, and about 250 from dihydrogesterone. And you can see that for those other progestogens, thousands of cases derived from these progestogens. This is very important, and although the power to analyze micronides and dihydrogesterone was very weak in this meta-analysis, the authors informed also that the risk appeared to be somewhat lower for combinations containing dihydrogesterone. It's important to emphasize also that the previous meta-analysis I've just presented did not take into account the data from the WHI trial. And in the estrogen plus progestogen arm of WHI, remembering that this study only evaluated conventional doses of conjugated estrogens plus medroxyprogestogen, there was an increase in the breast cancer risk similarly to the previous cohort studies and to the and similar also to the meta-analysis, but without increase in the mortality breast cancer associated with breast cancer. On the other hand, and differently from the previous observational studies, estrogen alone decreased the risk of breast cancer, or at least did not increase, but that information was not covered by the meta-analysis, by the collaborative group in the previous meta-analysis. That's important to remember this aspect. But since some years ago, there has been interest to better understand the effect of different progestogen on breast cancer risk. And this French cohort, very well known also, with more than 80,000 women published in 2008 with a mean follow-up of 8 years, showed some difference regarding the different progestogens. And we can observe first in this graph, this first column, women without menopause hormone therapy. And here we have the relative risk 1, our reference, the reference of the study. Estrogen alone increased the risk by 1.29, very similar to previous cohort studies. At the right, we can see estrogen plus synthetic progestogens, and the risk was even more, of 1.69. But the interesting is in the middle of this graph. And we can see here the association of estrogen with progesterone or dihydrogesterone. And the relative risks here were 1 or 1.16, no statistical difference in relation to the reference group. And this showed us that according to the progestogens associated in our hormone therapy regimen, the effect, the action in the risk of breast cancer may be different. And in 2020, Vinogradova and collaborators also evaluated the effect of different progestogens. And again, what we observe is that for that same synthetic progestogens, medroxyprogesterone, levonorgestrel, norethistérone, there was an increased risk for breast cancer. And this risk is progressively higher the longer time of using the hormone therapy, as we can see with the diamonds showing even higher risks with the higher duration of the therapy. However, when they analyzed the effect of dihydrogesterone, it was observed that up to 5 years, there wasn't increasing risk of breast cancer. The risk only appeared for use greater than 5 years, and even in a smaller magnitude than that observed observed with the other progestogens. It's very clear in this graphic, the difference between the other three and dydrogesterone. Another interesting point of this study is that when they restrict the age group from 50 to 59 years old, which is very interesting for our practice, because this is the main group for which we usually prescribe the hormone therapy, there was still an increase in risk with those first three, of course, medroxy, levonorgestrel, norethindrone, but there was no increase with dydrogesterone down here, as you can see with the diamonds around the risk relative 1, even for use with 5 years or more. Of course, in subgroup analysis, there is a reduction in the sample size, and thus the statistical power is also decreased. But there is a clear indication that dydrogesterone has a smaller effect on the breast cancer risk, smaller than other progestins. Now speaking briefly about the different progestogens and the cardiovascular systems. In this first slide, I bring some information from WHI and cardiovascular outcomes. In the left graph, we can see estrogen plus progestogen arm. In the right, we can see estrogen alone arm, both from Women's Health Initiative trial. And we can see that although many limitations, several misinterpretations in this study, but we can see that hormone therapy in this specific study increased the risk for coronary heart disease, for stroke, for venous thromboembolism. Remembering conjugated estrogen, conventional doses higher than nowadays, major part of women after the window of opportunity, but those are the results of WHI in the estrogen plus progestogen arm. But when we look at the estrogen alone, isolated estrogen, we can see that there wasn't an increase in coronary heart disease, and even this increase in venous thromboembolism was less important, had less magnitude than those of the estrogen plus progestogen arm. And in this case of estrogen alone, this increase was not statistically significant. So to me, it's clear that the association of that progestin increased even more the cardiovascular risks in WHI. Other information, as another example, this other study that evaluated, instead of medroxyprogesterone, but norethindrone, it showed us that estradiol are good for lipid profile, decreasing total cholesterol, increasing HDL, decreasing LDL, so decreasing the ratio LDL-HDL. But when norethindrone was added, the blue bars here, the beneficial effects of estradiol were partially suppressed. The increase was much smaller in HDL, the decrease in LDL was much smaller. Again to WHI. WHI also evaluated the effect of menopause hormone therapy on lipids and glucose and insulin and other aspects. And here the history is very similar, because conjugated estrogen alone increased HDL, but when medroxyprogesterone was added, it suppress this part of this increase. The same when we look at the carbohydrate metabolism, at insulin resistance, we can see a suppress impact, a suppress of the beneficial effect of estrogen on this aspect also. And going now to the effect of hormone therapy composed by dihydrogesterone and estradiol on lipid and carbohydrate metabolism. In the left graph, we have first the control group here. And we see that menopause was associated with an increase in LDL. There was almost stability in HDL, a small increase, in glucose. And when we look at the hormonal therapy made with estradiol and dihydrogesterone, there was a significant increase in HDL, a decrease in LDL, a decrease in glucose. And at the right, we can see HOMA-IR showing that the insulin resistance was much more decreased with this kind of hormone therapy composed by estradiol and dihydrogesterone. So we can of course, this data did not allow to see the magnitude of dihydrogesterone impact compared to estrogen alone, to estradiol alone, but at least the association estradiol dihydrogesterone was not deleterious, was not so deleterious to lipid and carbohydrate metabolism. On the contrary, it showed a positive impact, especially in this part of the information. And now we look at thrombosis. This data from Esther study, we have several other studies, and of course, in the Esther, the main objective was not to evaluate the effect of different progestogens, but evaluate the route of administration of estrogen. And we clearly see that oral estradiol increased the risk of venous thromboembolism. We can also see that transdermic estradiol did not increase the risk. But when we look at the progestins, we may see that when estradiol were associated with a norepinephrine derivative, for example, of norepinephrine derivatives, megestrol acetate, promegestone, and so on, there was also an increase in venous thromboembolism. On the contrary, when estradiol was associated to micronized progesterone or a pregnant derivative, examples of pregnant derivatives, dihydrogesterone, medroxyprogesterone, and so on, there wasn't an increase. Of course, we have to be very careful in interpreting this study because it was not designed for this purpose, but it's one more piece in our puzzle, and it helped us. It helped to show us that maybe even for venous thromboembolism, there may be different effects of different progestogens. Of course, a large study comparing the effects of different progestins on cardiovascular outcomes is lacking. But we have to reason with the data we have. And the data we have show that there are several differences according to the progestins, to the chosen progestogen, in the effect of cardiovascular disease. And now to finish, I bring this review, published this year by Professors Langer, Hodges, Lobo, and Allison, And I highlight these parts. Unfortunately, among many women and clinicians, the perception of HRT benefit risk is distorted, and its use avoided, leading to unnecessary distress. When initiated within 10 years of menopause, HRT reduces all-cause mortality and risks of coronary disease, osteoporosis, and dementia. And this is, of course, focused, this review focused, or at least this phrase focused, on the window of opportunity for hormone therapy. But I highlight here not only for the purpose of window of opportunity, but also to remind the importance of an adequate choice of the hormonal components of the hormonal therapy. The components of hormone therapy, and especially progestin, may have several effects in our patient's health. And our take-home messages, First, all progestogens are not the same, because according to their biochemical structure, they may have different actions, and these actions may be more or less favorable. With regard to breast safety data, we may say that dihydrogesterone and micronized progesterone may decrease or at least not increase the risk, or not increase as strongly as other progestogens. Levonorgestrel, norethistérone, and medroxyprogesterone acetate increase the risk of breast cancer when in a hormone therapy regimen, while there is positive data for other progestogens. Regarding cardiovascular risk, it's noticed that there is less interference on the benefits brought by estradiol with combined the combined use of micronized progesterone or dihydrogesterone. And finally, long-term menopause hormone therapy with selected progestogens is safe. I thank you for attention. It was an honor to present this data to all of you, and I excuses for my not so good English, but I hope I could transmit the information, and I continue here to answer the questions. Thank you.
Thank you, Dr. Pompei, for such a wonderful presentation. Now we will begin the Q&A session, and we encourage you to continue submitting your text questions using the Q&A widget you can find on the bottom part of your control panel. Professor Simoncini, the floor is yours.
Thank you so much. I truly enjoyed your lecture, Luciano. It was a wonderful lecture, very, very clear. Congratulations. And actually, you have a wonderful English. So I think it was very well received. We have already a few questions. So as Lina said, whoever has additional questions, send them in the question and answer application in the bar, in the Zoom bar. So let me start with first questions first. So the first question was casted just after your start in the presentation, and it is a question on choices. So let me read the question. How does one decide whether to choose oral tablet with estradiol and dihydrogesterone as compared to estradiol and progesterone? So would they be a first-line oral treatment if there is no indication or contraindication for transdermal? So this is, I think, it's a very good question, because you, Professor Pompei, said repeatedly during the presentation that dihydrogesterone and progesterone have similarities in terms of clinical outcomes on the breast, on the cardiovascular system. So would you comment on how you choose between the oral associations with progesterone or dihydrogesterone in your clinical practice?
Thank you, Professor Simoncini. And I believe the first aspect is that regarding the metabolism, dihydrogesterone and micronized progesterone are very similar and interchangeable. What I see is that on the bleeding control, there is some difference. In my opinion, and taking care of patients, I noticed that dihydrogesterone is a little better in controlling the bleeding and in the bleeding pattern. So in this aspect, I believe there is a small superiority of dihydrogesterone. And there is a recent meta-analysis evaluating the risk of endometrial cancer. And in this meta-analysis, the traditional progestins were very good for endometrial protection. Dihydrogesterone was also good, and micronized progesterone, at least in that meta-analysis, decreased, but not as strong as the other progestins. So I believe in my practice, at least, I'm prescribing dihydrogesterone frequently.
Okay, thank you very much. Now, a question on myomas. There's a question on if you have a patient with the menopause, of course, and myomas, is there a better treatment? Is there an HRT, menopause hormone therapy that you would choose as a first choice, or it doesn't matter?
In a patient with myoma?
Yes.
The first message is that leiomyoma is not a contraindication for hormone therapy. Is this important to emphasize? Because I don't know here, but in Brazil, some doctors believe this, and it's important to emphasize that there is no contraindication. Usually in myomas, I start with in the same way I do with other patients. And I change the progestin when the pattern of bleeding is not adequate. So I start as the others, and if the pattern is not okay, I change to a more atrophic action progestin like norepinephrine. But firstly, I tried dihydrogesterone or micronized progesterone.
Yes, this makes a lot of sense to me as well. And there's a question on the risk of deep vein thrombosis. This comes from Dr. Navani. I think the question refers to the data that you presented when you showed that you have no increased risk of deep vein thrombosis with oral estradiol plus dihydrogesterone or progesterone, while oral estradiol on its own had showed some increased risk. So the question is, why is it that when you combine these two types of progestogens, micronized progesterone or dihydrogesterone to estradiol, the risk is reduced as compared to estradiol? Are you aware of any mechanism for this?
These studies did not have power to analyze if in the same group of progestins with transdermic or oral estradiol is the same. Of course, there is a risk, and I was cautious at the end of presenting that study that there is the possibility of a non-equilibrated distribution of estradiol route of administration between the groups, and of course we have to evaluate better this aspect, but possibly the norepinephrine or even the testosterone-related progestins may increase the risk. Perhaps it's, I'm supposing, via glucocorticoid receptor or other actions. It's not clear what's the mechanism.
Okay, no, that's absolutely clear. There's a question on the risk of breast cancer when you use the levonorgestrel loaded IUD, the intrauterine system. Is there any data that there's an increased risk of breast cancer in these patients?
We don't have a good, we don't have studies about the effect of intrauterine device with levonorgestrel in the risk of breast cancer in postmenopausal women, not in contraception, but as part of a hormone therapy regimen. But considering that only a small proportion of levonorgestrel circulate in women using intrauterine device, probably the risk is less increased than the traditional systemic use, probably less increased, but there is no adequate study to be definitive in this conclusion.
Okay, fantastic. There's a question on again, well, the question states which progestin is safer in terms of breast cancer between dihydrogesterone and micronized progesterone. I think you addressed that in your presentation already. But in the question, there's also a mention on endometrial cancer. So you already commented on the bleeding pattern, the differences between progesterone and dihydrogesterone, and why you, in some instances, prefer dihydrogesterone compared to MP. But is there any evidence that in terms of preventing breast cancer, I'm sorry, endometrial cancer, they do perform differently?
Of course, we don't have enough studies about this, but the impression, and taking into account the recent, another recent meta-analysis, which I have mentioned, it appears that dihydrogesterone is better for endometrial protection than micronized progesterone. Of course, there is a question related to bioavailability of these progestins, because progesterone is difficult to have a good absorption of progesterone. Of course, this technique, this pharmacological technique to micronize it, increase the absorption, but the bioavailability of progesterone is less than those of dihydrogesterone. Of course, there is a question about the age, also the duration of the cycle and the dose of the progestins. But at least in the studies, it seems that dihydrogesterone may be more effective in protecting endometrial.
Fantastic. And I think it's made it very clear. And there's a complex question. I don't think it's actually a complex question, but I think it's a very sensitive question. If you have a woman who has already had ischemic heart disease, for instance, you have stenosis in the left descending coronary artery, or she has a stent, something like this. So is it safe to give her menopause hormone therapy? What is the data?
Well, for answer this, we have to go to her study. And in her study, of course, conventional doses, equine estrogen, and of course, we have to take this into account, but in her study, there was an increase in risk of a new cardiovascular event on the first year, not during all the time. During all the time, there was no difference between HRT and placebo, but in the first year, there was an increase in the risk of a new cardiovascular event. So due to the HERS results, usually it's considered that there is a contraindication for hormone therapy after a cardiovascular event like myocardial infarction and so on, or presence of a stent. So usually considered as a contraindication. This is also listed in our Brazilian guidelines. We have a chapter about the contraindications, and we consider, due to the HERS study, that there is contraindication in this case.
Okay, fantastic. This is also very clear. And there's a question which is interesting on women with high cholesterol. So these are not necessarily at very high cardiovascular risk. It depends on co-presence of hypertension or other conditions. But in these women who have high cholesterol levels, do you choose oral or transdermal menopause hormone therapy? And eventually, you have a progestin that you prefer to use?
First of all, it's important to say that both route of administration of estradiol decrease cholesterol, decrease LDL, and increase HDL. But oral route is more effective in increasing the HDL. This is very clear. The important point is triglycerides, because if triglycerides is high, we prefer the transdermic route, and if it's not right, you may use both oral or transdermic. With cholesterol, with high cholesterol, of course, oral estrogen will be better, but transdermic estrogen also decrease LDL.
Absolutely. There's a question on the regime of co-administration of estrogens and progestin for the risk of breast cancer and endometrial cancer. So the question is there any difference? Is it better to use a continuous combine as compared to a sequential combined regimen in order to reduce the risk of breast cancer? Do you know of any data comparing the two ways of administration of menopause hormone therapy?
The studies showed that for sequential combined hormone therapy, differently, estrogen alone increases, of course, the risk of endometrial cancer. This is very well known. When we look at the combined hormone therapy, if it's continuous, progestins every day, the studies show similar risk in relation to non-hormone users, or even a decreased risk compared with placebo users, like in WHI. If the regimen is sequential, some days of progestin, some days without, usually 12 or 14 days with progestins, the studies show no increase or a small increase in the risk of endometrial cancer, but much less than with estrogen alone.
Yeah.
Was it your question?
Yeah, I think it was clear. I don't think there's any evidence around that the sequential as compared to continuous combine has any major impact. As you said, if you give progestin for at least 12 days a month in sequential, and with sequential there's no long-term data observation, because usually we use it as we all know very well, for the first months or a couple of years after menopause. There's very few women who use sequential for a long time. It's generally prefer shifting towards continuous combined. So I think that's the data that we have in our hands. There's an interesting question on body mass index. So is there a certain level of BMI that is for you the threshold for deciding to shift between oral, eventually with dydrogesterone or micronized progesterone, towards transdermal? because over a certain BMI, some guidelines, for instance, the BMS guidelines advise to use the transdermal estrogens. So I don't know if you have a limitation, a threshold in your clinical practice that you use.
No, transdermic estrogen is, of course, a very, very good option because of the venous thromboembolism risk. And it's very common here to use transdermic estrogen and add an oral progestogen, for example, dydrogesterone or micronized progesterone or others. And of course, we have to take some aspects in consideration. For the most part of patients, the route of administration have not so many impact, but for some specific patients, we may see some impact. For example, for hypertension, patients with hypertension, patients with an increased risk for venous thromboembolism, patients with an intermediate risk, cardiovascular risk evaluated by the cardiovascular calculators, and so on. But I believe that we have also, in many cases, we also have to share this decision with the patients, because some patients prefer the oral route, and if there is no contraindication for using oral route, why not? But I believe that there is some technical questions, of course, but we have also to listen to the patient and to notice her perception and her preference.
That's very sensitive, and I totally agree with you. So sometimes it's best to provide something that the patient likes so that she complies with the therapy over a long time. An interesting question on, is it possible to use progestins, progestogens, whatever, to improve as a standalone therapy, so without estrogens, to improve menopausal symptoms? And eventually, if you do that, is there a risk for breast cancer associated to using only progestogens after the menopause?
Sorry, without estrogen?
Yes, without it. So using only a progestin to alleviate menopausal vasomotor symptoms.
I believe I usually not prescribe only progestin here. I have no experience with only progestin in the past. The experiences were not so good. So usually we don't prescribe only progestin for menopause treatment. Usually when the patient couldn't use hormone therapy, we go to the second line, which is serotonin inhibitors, reuptake inhibitors.
Yeah, that's the reality. Any suggestion for a patient with endometriosis? Do you prefer a specific type of menopause hormone therapy? Do you choose a specific progestin?
Yes, for endometriosis, for example, I like it nomegestrol. I believe nomegestrol is a very good progestin for endometriotic patients, and Dienogist also is very good options.
Yeah, there's two final questions, and then it's been really a nice discussion. So I would like really to thank also the audience for providing. I didn't have to provide any personal question. They were all from the audience. So a lot of it. You had really a wonderful presentation.
Thank you.
So there's a question on long cycles progestin. So, can you use progestins for long times? I believe this question applies more to the perimenopause period. So when we can treat women with progestins over a long time, avoiding estrogens. So do you have any comment on this type of approach?
I believe perhaps the question is about to use progestins in larger intervals, perhaps from 3 to 3 months or 4 to 4 months, and something like that. And this is considered nowadays an exception regimen. usually prescribe estrogen for women without uterus, as to progestin for women with uterus. In women with uterus, non-hysterectomized, cyclic, sequential, every month, or continuous. If the woman has intolerance or adverse effects with the progestins, we may the regimen longer, every 3 or 4 months. But the studies show that with these longer intervals of progestins, the risk of endometrial cancer is increased also. Not as much as estrogen alone, but it's higher than those of continuous combined hormone therapy. So I consider as an exception regimen for those women who could tolerate the other regimens.
Fantastic. And the last question is about tibolone and breast cancer. Do you want to comment on the risk of breast cancer with tibolone?
Yeah, the Million Women study showed that tibolone also increased the risk of breast cancer by a relative risk of 1.3, 1.4. But the problem is that there was a bias in prescription in the past when doctors perceived that, have the impression at least, that tibolone was good for the breast, could decrease the risk. And so there was a trend to prescribe tibolone for women with a higher breast cancer risk. Probably this influenced the results of Women Million study. And when we look at the LIFT study, which evaluated tibolone low doses to placebo in order to avoid to protect against the risk of fractures in women over than 60, tibolone decreased the risk of breast cancer. And on the other hand, in Liberate study, women already with breast cancer, treated of breast cancer, received tibolone for alleviate the symptoms, and there was an increase in risk of recurrence of the cancer. So the impression putting all together is that tibolone probably does not increase the risk, at least not in the same proportion that estrogen and estrogen plus progestin, but there is some controversies yet. My impression is that there is no increase of the risk in breast cancer with tibolone, but it's not, it is contraindicated after breast cancer.
Well, thank you, Professor Pompei. It's been a very interesting lecture and a lovely discussion. So you really made a good job of this webinar. I think everybody enjoyed it a lot. I personally enjoyed it a lot. So thank you for showing all this data. So I think we are now at the time where we need to close. I'd like to thank again Abbott for supporting this initiative. There is an EMAS, the European Menopause and Andropause Society initiative. I would like to thank Lina for the wonderful organization, and I would certainly love to thank Professor Pompei for giving this enjoyable presentation and this for staying with us so long for the discussion. Thanks a lot. It's been wonderful. And I remind everybody that this webinar will be available on the EMAS website starting from next Monday. So whomever wants to repropose it to friends or colleagues or wants to re-listen to the discussion on the presentation, you have the chance to go there. Thank you so much.
Thank you. Thank you. Bye.
Bye-bye, everybody.